Hello, I'm Dr. Michael Berry. I'm a general internist at Massachusetts General Hospital in Boston and one of the three collaborating principal investigators on the TRUST trial. And the plan for this presentation is to give you an overview of the TRUST trial, which is short for the Treat to Target Serum Urate versus Treat to Avoid Symptoms in Gout, a randomized controlled trial. And you'll hear some more details in subsequent presentations, but we'll start with the overview. So brief history of the TRUST trial. The TRUST trial evolved from a debate about optimal primary care management for people with gout in the general internal medicine and rheumatology communities. The general medicine approach focused on treating to avoid treating gout flares effectively to minimize symptoms. And we abbreviate this TTA-SX, treat to avoid symptoms. The rheumatology approach focused on reducing serum uric acid below a target value to try to eliminate flares. That's called the treat to target or TTT strategy. Both approaches may be right for certain people. General internists tend to care for people with less severe gout than rheumatologists who see more gout complications. Now, there's no good data that compares these two primary care management strategies in terms of the occurrence of gout flares. Many patients in primary care prefer simply treating gout flares as they occur rather than taking a preventive medicine every day. Patients can become quite expert at avoiding flares through lifestyle changes and managing their flares to minimize pain and functional limitations. An added issue is that when urate-lowering therapy is started in a treat-to-target approach, more flares can be triggered as the urate levels fall. As current evidence does not favor one strategy over another, and clinicians disagree on the optimal management strategy, a state of what we call clinical equipoise exists, the ideal situation for a trial. We'll talk about another form of equipoise a little later in the presentation. Now, representatives from both communities, the general internists and the rheumatologists, worked to design a study to compare these two management strategies in treatment for people with gout. These discussions led to the TRUST trial, which has been funded by NIH and NIAMS, the agency at NIH that covers rheumatologic diseases, to see which management strategy is better in terms of a lower number of gout flares. The study has been approved by the Central Institutional Review Board, the IRB, at Mass General Brigham. Now, the TRUST trial will randomize 650 eligible participants to the treat to avoid symptoms or treat to target strategies of care. 6 academic medical centers and their primary care practices will participate, each recruiting about 110 patients. About 55 of those will join the treat to avoid symptoms arm, and another 55 the treat to target arm. Our sites are Massachusetts General Hospital and Brigham and Women's Hospital, the University of Alabama at Birmingham, Boston Medical Center, New York University, and the University of California at Los Angeles. Each site will have 2 nurses to separately manage each arm of the study. The nurses will be part of a study team at each site, including a study coordinator, a research assistant, and 2 investigators, both a general internist and a rheumatologist. Each patient randomized in TRUST will be followed for 24 months. The primary outcome will be the number of gout flares in each group, but a secondary outcome will be quality of life measurements during the study. Research assistants blinded to which arm the participant is in will contact participants either by phone or through messages from the portal in the electronic medical record every 2 weeks to monitor for gout flares. So that recording of gout flares is not something the nurses will need to do. Here's a schematic of the TRUST trial, basically starting with randomization to the 2 study arms, treat to target serum urate or treat to avoid symptoms, and the aims of the study. We've talked about aim 1, comparing gout flares and quality of life. There's another aim, and that's to look at established cardiometabolic renal intermediate endpoints over 2 years, things like kidney function, blood sugar, blood pressure. And as you see from the timeline below, there are periodic visits that we're going to cover in detail in a subsequent presentation. The nurses will have those regular visits, some in person, some can be virtual, with participants in both groups to educate them about gout, help them better manage any flares, and provide study gout medications. One of the benefits of a person joining TRUST is that their gout medications are supplied free of charge. The treat to target arm nurse will also work to help the participant lower their uric acid levels below a specific target using serum urate measurements to guide those changes in therapy. The treat to avoid symptoms arm nurse will focus on reducing the frequency and severity of gout flares using lifestyle changes and medications for flares, but without urate measurement. In TRUST, all participants, as I said, will be given those gout-related medications free of charge when they have their visits with the study nurse. To be eligible to be enrolled in the study, each patient must be 18 years of age or older, be in a participating primary care practice at one of our 6 sites with at least 1 visit in the previous 36 months. They need to be diagnosed with gout by the 2015 ACR-EULAR, the official criteria, 8 or more points on their criteria scoring algorithm. Have experienced at least 1 gout flare attributed in the previous 12 months and have a baseline intercritical, that means between the flares, urate level of 7 or higher. And it needs to be intercritical because during a gout flare, the urate level can dip and be misleading. So we want that uric acid between attacks, and that value needs to be in the previous 6 months. And of course, they need to be willing to provide consent to be assigned randomly to either study arm. We talked about clinical equipoise among clinicians earlier on, but we're looking for patients who are at personal equipoise as well. They'd be willing to be randomly assigned to either treatment. There are some exclusion criteria, mostly because of the study medications being used. So people with severe chronic kidney disease with an eGFR less than 45 are excluded. If they have more than 1 subcutaneous tophus, that's a collection of uric acid crystals in the joints, sometimes on the ear, they'd be excluded. If they've had 2 or more episodes of renal colic, kidney stone pain in the past 5 years, because uric acid can cause kidney stones. If they can't provide informed consent, if they have an elevated transaminase liver function test within 6 months, that's 3 times the upper limit of normal. If they're pregnant, planning pregnancy or breastfeeding, if they're taking mercaptopurine or azathioprine, which interfere with the study medications, if they're unlikely to survive 2 years because of comorbidities, if they're currently taking more than 200 milligrams of allopurinol, allopurinol is our main urate lowering therapy in the TRUST trial. But patients taking 200 milligrams of or less of allopurinol may participate, provided they meet the other eligibility criteria. In other words, they've had a flare over the past year and their uric acid level, despite the allopurinol, is 7 or higher. And that's acknowledging they shouldn't have had their dose bumped in the last 6 months. Patients with known allergic or hypersensitive reactions to allopurinol and not willing to initiate febuxostat if urate lowering therapy is indicated. Again, allopurinol is the main urate lowering therapy. Febuxostat is a backup option for lowering uric acid, which can be used in the study, provided patients agree. Now, I've reviewed the inclusion and exclusion criteria But our study nurses really don't need to worry about those criteria, as there'll be an assessment of eligibility when patients are recruited, and nurses will meet the patients downstream from that when they're randomized to one of the two study arms. So the eligibility criteria and exclusions will be taken into account. That's my overview of the TRUST study. We're glad to have you aboard. And in our subsequent presentations, we'll get down to details of how our participants in the TRUST trial will interact with our study nurses and other personnel. Thanks very much for your attention. I look forward to working with you.